Hi everyone, welcome to another Facebook Live session. Um, Today I'm going to be talking about menopause and how that relates to mothers. It's a topic that um, you know, I think a lot about because again it's a transition, a very important transition in a woman's life, just like birth and becoming a mother is such an important transition. And my feeling has always been that menopause in mothers is seems to be potentially quite a different experience, um, both on the positive side and also on the negative side, potentially with those negative symptoms associated with menopause. And now, something that I've always been very curious about is what was menopause like for the ancient woman. I did classical studies at high school, I did Roman studies at university, and I was certainly aware that with a lot of the descriptive texts, they talked about the stopping of the bleeding and becoming a wise woman, essentially, which in ancient cultures, the menopause really represented upgrade in your social status. Um, but there wasn't so much mention of these quite horrendous symptoms, physical symptoms, and emotional symptoms that can occur. And so I've always been curious is this menopausal struggle a more modern phenomenon? Um, and so today, what I'm hoping to do is just cover some of the historical uh, aspects around what's known about menopause, um, where the current thinking is about menopause, especially from a neuroscience point of view, and then also regarding mothers and menopause. Um, I just had a mother recently with two young kids, and she was 47, and here she is starting to experience menopausal symptoms, being very affected by them, and she's got two young kids under the age of five, and she was really wondering um, what on earth was hitting her. And then also, I'm seeing a lot of the this phenomenon of a woman going through menopause. At the same time that their child is going through teenage hormonal uh, um, turbulence, if you like, and then that may be the daughter starting her menarche or starting her period, or a boy that's starting his hormonal sort of changes. And so I think it's, from a social point of view, this is quite um, a new situation because we're having kids um, much older nowadays that mother at menopause and then the children in those sort of teenage years. Um, so I'll talk a little bit about sort of the history of menopause. It's interesting. It's not the most kind of warm, fuzzy thing to sort of look at. And there's a great book if anyone's interested by Louise Foxcroft, Hot Flushes, Cold Science: A History of the Modern Menopause. And then there's has been quite a bit written about this through sort of various channels. So the term menopause, interestingly, was coined by a French doctor in 1821, um, and it came from the Greek meaning the monthly stopping is what menopause means. And so the idea of the menstruation that was occurring monthly was stopping. That's what the term menopause actually means. Um, and what's also interesting is that the French during this time and up until the early 20th century certainly looked upon women's health and menopause much more kindly than European sort of counterparts, and especially the English, who were very um, uh, uh, yeah. It's hard to imagine um, a woman being treated at that time as often second-rate sort of citizens, and I'll give you a few examples of that. Um, the first mentions of menopause in sort of historical texts are Aristotle, and he mentioned that a woman could start this menopausal time from the age of 40, but and she couldn't get pregnant beyond the age of 50. So that was kind of sort of noted. Um, Again, the historical texts don't talk a lot about the sort of these sort of severe symptoms that we know too well in our 21st century culture. There have been some very full-on things written about menopause during the Middle Ages, and I'm just going to go over a couple of them. In 1584, the famous book Discovery of Witchcraft by Reginald Scott claimed that upon stopping of the monthly melancholic flux or issue of blood, um, he felt that older women were more likely to command the devil due to the build-up of that particular body fluid. And so, and you know, there are plenty of accounts during the witch hunts of menopausal women being really sort of targeted, uh, probably because of their wisdom, as much more than the fact that they are having menopause. But it's they seem to have been especially sort of targeted during Victorian England. Um, Now they certainly had some very odd treatments for menopause, including opium, morphine, and lead injections into the vagina. And for a while, there was even surgery for menopause, including removal of the clitoris to stop hysteria, and a number of other quite barbaric things. Yeah, and the other thing that really I came across was that up until 1710, um, everything that you can find in the literature viewed menopause as natural, as healthy, um, uh, and not as something where after that a woman was being um, perhaps having an illness, if you like. I mean, even with said about sort of the witchcraft, I mean, it was still considered to be just a natural part of life as opposed to an illness. So after that time, it was definitely discussed. Um, yeah, and there's just lots of other things that I won't talk about today, but it's certainly a sad tale. And later on in Victorian times, the treatment du jour was opium, wine, and cannabis, interestingly, to help with climacteric insanity, which, uh, and even at that time, they started to use powdered ovaries and testicles, understanding that somehow hormones were involved with this. Um, yeah, but I won't labour that too much, but certainly it's had a pretty checkered history. And um, also looking through, I'll just sort of share one more thing with you. This is my sort of textbook from 1935. It was one of the first textbooks on women's health, so it could be considered a medical textbook, if you like, from that time. And it's got a very interesting chapter on menstruation and the sensation of menstruation. And to be honest, I can't really understand a lot of what it's saying. Just for example, they divided women into 5 different types during menopause. Um, the Platonic type, the intersexual type, the status hyperplasticus, status hyperplasticus, and status stenus copitus. And I read through each of these, and I couldn't actually understand what it was sort of saying. So it was just um, it's like they're describing lab rats or something. And so this is essentially a little bit of just where we've come from as a culture and a little where we've come from as uh, a society, really, not really understanding um, the. I'm presuming that ancient cultures had a very healthy handle on menopause, and then with the Renaissance and then the Victorian Europe actually starting to treat menopause as an illness. And then these very barbaric sort of treatments. And even looking at sort of the modern medical texts, it's very narrow in terms of the descriptions, and it's certainly not looking at it as part of a life context, um, and it's certainly not honouring it as such an important transition in life, which I think we all need to be really, uh, rather than something that needs to try to be avoided through pseudo youth, something that maybe should be embraced more. So, in terms of a little bit of the neuroendocrinology, so a little bit of the brain science of what's going on, it's really quite fascinating. Again, not really well understood, like so many things in women's health. But what we do know is that menopause essentially starts from the age of 40. And what I mean by that is that those early changes that are associated with menopause are first starting often 10 years before the menopause is setting in. In Australia, the average age of menopause is 51 and a half years, and menopause by definition is having 12 months without a menstrual cycle. So again, um, starting that menopausal period at just after 50, and then averages differently in different countries, but it's considered normal between 45 to 55 to actually have finished 12 months, no menstrual bleeding. But the whole process starts in your 40s, and the first things that do happen are just a more erratic production of hormones, estrogen, progesterone, and the gonadotrophins, which are the brain talking to the ovaries, and we start to see a lot more variation month to month, cycle to cycle, and just over year on year. And the other thing that happens as a result of these fluctuations is increase in the activity of the default mode network. And so the default mode network is when it's almost like the screensaver on your computer. It's when we're not necessarily daydreaming, but when we're not really thinking about anything or having to really process anything, the brain goes into a default mode. And because of these hormonal fluctuations that are occurring, there is much more activity in that mode. The reason why that's important is that can really, if you have increased activity in this default network, you can be more easily tripped into anxiety and um, more extreme emotions. What we know from a mother's point of view is that after you've become a mother, you start to have shorter menstrual cycles, and you end up having lower amounts of this key estrogen, so the primary estrogen called estradiol or E2, and you start to get average overall lower levels of that. And um, what the research is uh, suspecting, and again, this research that I'm looking at is from this year, so it's super recent, 2020. Um, it's looking at when motherhood goes well, and you have these high amounts of estrogen during pregnancy, and then these lower amounts of estrogen after children or in between children. Um, this is actually neuroprotective. It's actually really healthier for the brain potentially than not having children or having problems with estrogen and neuroinflammation during the pregnancy and postnatally. So it's mothers also tend to have much healthier um, T T regulatory cell function, and that the T reg cells are like the generals of your immune system, if you like. So there's better coordination, and because of um, fetal microchimerism, the baby cells coming into the mother's system and staying in there for up to 30 years, that is also thought to have a neuroprotective effect for the mother. Again, there seems to be a sweet spot. And again, like many things if there's too much or too little, we were outside that sweet spot and we probably lose that neuroprotective effect. So I think mothers by design are going to have a healthier brain moving forward. But if they've had a really difficult time with the pregnancy and postnatally with a lot of these neuroinflammatory things that I'm always talking about, depletion, anxiety, depression, overwhelm, um, not only may the mother lose that neuroprotective benefit, but there actually may be more aging of the brain as time goes on. So obviously that's not a good thing. Again, this is just my theory, but from how I'm kind of looking at my clinical work and how I'm reading this very early research, I'm really seeing that there is this kind of sweet spot, and so with a lot of the work that I'm doing with mothers, I have a real sense of mothers who are struggling postnatally who are probably heading towards a really difficult menopause. There might be a family history of uh, severe menopausal symptoms, and there may be already a lot of what they call neuropsychiatric symptoms, so already a lot of anxiety, a lot of um, uh, premenstrual tension, and symptoms around that. And this is where a lot of my interest has really started from how to not only help a mother in the here and the now, and to recover from postnatal depletion, but to also set her up for a healthy menopause. And I think that's definitely something that can be done and that we should be really sort of looking at. Um, uh, so just to continue on with the with a bit of the neuroscience, there seem to be three key factors that may set you up for a good menopause or may set you up for a horrendous menopause. And these three key factors are number one, whether if you have too much noradrenaline in your brain, and I'll explain a little bit more about that. Two, if you have a sudden drop of estradiol, and I'll explain more about that. And then if you have an upregulated alpha adrenergic system, which is a fancy way of saying central nervous system activation through the autonomic nervous system. So hyperarousal. That's fight or flight part of the nervous system. It lives in the body and not in the brain. When it's in the brain, that upregulation of that fight or flight within the brain is a key factor of heading towards a troublesome menopause. With the noradrenaline issue, this is more around when there are a few things that can really contribute to that. One is when there isn't enough of the relaxation response engaged. It's just stress, 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 stress. You can do, some women do quite well with stress, 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 stress as a dynamic. So it's not that they're necessarily upregulating that central part of the fight or flight response, but not engaging the relaxation response means you end up getting more noradrenaline in your brain over time. And there are a couple of other things, including mineral imbalances, especially copper high, zinc low, and manganese deficiency that may really contribute to increases of noradrenaline in the brain. And then with the sudden drop of estrogen, so what should be happening from 40 is that overall our estrogen should be dropping from 40 to 50. If for whatever reason your estrogen is not dropping or it's actually increasing over that time, and then you have a sudden drop heading into menopause, that's going to set you up for a way worse time. So those three factors, I think, is where a lot of the research is heading. Noradrenaline in the brain, a sudden shift in the amount of estrogen in the brain, and then this upregulation of the fight or flight system in the brain. Now, with menopause, now all the action in terms of what a lot of people are sort of experiencing, Uh, so we'll talk a little bit about sort of might just change. We'll stick on this topic. So most uh, when we're talking about menopause, what are we actually talking about? And it's not just the stopping of the bleeding, and there are four sort of fairly key areas that can be real symptoms and problems during menopause. The primary one is vasomotor, so that has to do with hot flashes and flushes. You have a lot of the psychological symptoms of mood, loss of self worth, uh, and uh, sexual dysfunction, loss of sexual interest, libido is a third set, and then you can have a lot of physical symptoms outside the vasomotor. So crawling, sensation on your skin is just one of those sort of symptoms that is commonly sort of talked about. So there's sort of four categories, if you like, and the main one that's really sort of talked about is the vasomotor. That's what's been most studied, and the vasomotor symptoms are directed in a very, very tiny part of the brain called the anterior hypothalamic area, the AHA. And this tiny part of the brain within the hypothalamus is very, very close to the part of the brain that in mothers is very affected because of postnatal depletion and a lot of the postnatal sort of psychiatric conditions. And so I'm always wondering when the real estate is that close, is that you would think that they are related. Um, and it, what happens is that there is a narrowing of what's called the thermoregulatory window. So more easy to sweat, more easy to shiver, essentially. And that's part of the changes that are occurring uh, from the age of 40. So narrowing of that window. So any woman is more prone to getting these vasomotor symptoms. And one of the things that can happen if these vasomotor symptoms, especially the hot flushes, if they're going on for too long, I mean over years, and they aren't properly managed and treated, you can actually get growth within some key parts or some key neurons within that part of the brain um, that will mean you're much more prone to having much longer term menopausal symptoms. So I often feel quite sad when I'm talking to one of my clients when they've been having these symptoms for many years that it's a lot harder or it takes a longer time of treatment, I suppose. And there are pharmaceutical industries working on some key uh, pharmaceuticals as they do to target this particular area. And the drugs that they're really looking on are something on this neurokinin B system. So these neurons have a funny name called the kisspeptin neurokinin B dynorphin neuron. So this it's a tiny cluster of neurons that can really um, wreak havoc for a woman at that time of her life. So um, and another thing that can really contribute to this vulnerability is an upregulated HPA axis. So the hypothalamus talking to the adrenals and vice versa. So some of the work that I will do is to see if there's dysregulated cortisol, because that's a real clue that you're more likely to have these severe vasomotor symptoms. The vasomotor symptoms actually start with extra electricity within the brainstem, and then they just slowly flood into this key part of the hormonal part of the brain, the hypothalamus, and then the whole body gets affected with that. And if a woman's overnight urine cortisol levels are high, if her hair cortisol is high, or her cortisol during the day tends to be flat, not this kind of nice up and down sort of curve that you get, but a much flatter curve, she is going to have a much more severe time with these vasomotor sort of symptoms. And so again, this is where stress regulation suddenly becomes such an important thing at this time. So I might just have a look at a couple of questions here. So Sarah's asking, do you think if a woman was to work on tending to healing anxiety and stress in her early 40s, she could help to improve that menopausal experience? 100%, and that's where I'm going to. And this is where I think we all need to be going to as practitioners or mothers in your 40s, really looking at that. So, and again, it doesn't have to happen at 40; it can happen at any time, really. But it's I think this is part of loss of resilience at the age of 40 in terms of what you can get away with. There's some really interesting work done, which I'll mention later through the Women's Brain Initiative, that really sort of talks to this. The Christina's asking, chemo put me into sudden menopause last year. I developed high anxiety and was losing my mind. Yeah, so the chemotherapy would have had effects on those three key parts of the brain, or three key systems that regulate the brain in terms of noradrenaline, probably crashing your estrogen as well, and then really activating that fight or flight system within the brain. And it can be a horrendous experience. I'm sure it was, Christina, in terms of what you experienced, and then hopefully you managed to find some good treatment to help with that. I will talk about treatment in a moment. If you have any more questions just around kind of the neuroanatomy, please post them now, and then we'll start sort of getting into a little bit about sleep. So sleep's interesting. This is where, and one of the things that I've always been a little bit puzzled with, why these hot flashes during sleep and drenching sweats, sometimes requiring not only pajama changes but changing the bed sheets. And that's extremely dramatic, and it's not something, again, that's written about sort of historically. And coming back to that point, I think the modern woman has experienced a very different type of stress to the woman of antiquity. I'm sure the woman of antiquity had heaps of stress, but she probably had a lot of relaxation as well. And the modern woman often curtails her relaxation in light of just having to keep busy doing other things. And so the modern woman is just, again, having that stress on dynamic on most of her life. And then as she starts to hit her late 40s, experiencing very severe symptoms. And that seems to be the pattern that I'm really sort of seeing. And being a mother, does that help with your relaxation? That can really increase your stress and your exhaustion and your ability to be able to sort of cope as well, in that sense of overwhelm. So, I think the modern lifestyle is really set up for women to have a very difficult menopause, unfortunately. So sort of researching the sleep aspect, I mean, because there were two things that really sort of came up for me looking at the sleep. One was this default mode network, and so again, if that screensaver in the brain is already increased in its activity, it makes more sense that you're going to have more problems because of the default mode network at night time. And the other interesting fact is that REM sleep or REM sleep, which is the dreaming state, actually helps suppress hot flashes and a lot of those physical symptoms because we have to paralyze the body to then go into sleep mode so we don't start acting out our dreams. And we have more REM as the night goes on. And REM being suppressing hot flashes, um, the types of hot flashes and flashes are very different in the first half of the night than they are in the sort of the second half of the night. Um, in the first half of the night, they're more likely to be triggered by activation. What I mean by that is either having an unpleasant dream or um, being uncomfortable or having some sort of angst whilst you're asleep, and that's more likely to uh, then trigger a hot flash. Whereas in the second half of the night, um, uh, hot flashes are much more likely to trigger the angst. So there's a very different sort of dynamic that's going on. But again, the research is pretty new on a lot of this. Paula's writing here. I've recently ended up seeing a cardiologist and a psychiatrist, and both have come back to perimenopause. Um, so I'm presuming, Paula, that you went to see the cardiologist for um, heart symptoms. Usually, a lot of symptoms that you might be getting are things like palpitations or arrhythmias or even an increased heart rate or um, a sense like there might be heart pain. And seeing a psychiatrist, obviously, if you're having a lot of emotional disturbance, anxiety, depression, loss of self worth, sense of hopelessness, easily overwhelmed, loss of concentration, poor cognition. Now, the list is pretty long. Uh, Psychiatrist is probably not the most gifted person in terms of really helping with that, even though um, in America, the only non-hormonal drug that's FDA approved are psychiatric drugs. So things like paroxetine and SSRI seems to have some benefit. Venlafaxine, because it works on that noradrenaline, seems to have some benefit. They're not as spectacular as you would think, but certainly prescribed a lot. Um, and yeah, so Paula, I think helping manage your perimenopause might really help your heart and symptoms and your mental health symptoms. So, and we'll talk. I mean, we might sort of segue on to sort of treatment now. I mean, treatment's a really big topic. I'm not going to cover everything today. I just want to give more a bit of an overview of treatment options. I presume that there would have been a lot more research done on menopause, especially from a non-pharmacological point of view. Yes, there are quite a few studies, usually quite a small number, and they're often quite conflicting findings. And my feeling is looking into this research is that there isn't one type of menopause, and um, uh, there are things that may be targeting different things, which then may be helping or not having an effect depending on what we're trying to target. So my feeling is, menopausal management needs to be much more individualized, um, uh, and to not just this cookie cutter approach of do we give you hormones or not, um, which seems to be the starting point at most general practice appointments, I suspect. Um, one of the interesting things with the Woman's Brain Initiative, this is a really interesting collaboration that's happening in America. Really recommend having a look at their work. It's their head scientist has a surname Mosconi, and she's written some really great opinion papers and reviews on menopause. And she's got a couple of key things that I'm just going to sort of share with you now that I think it just pearls that I think are worth sort of looking at. So Number one, menopause starts in the head, so protect and invigorate the brain. Um, Pursue new intellectual activities. And so one of the things that she's really saying is important is it's not getting better at the things that you know, but learning something that you don't know seems to have some real benefits for brain health, and that is going to then have downstream effects that really help with menopause because it's going to help with that stress response, relaxation response is going to help with noradrenaline and those other things that we sort of mentioned. Um, Uh, After the age of 40, liver function slows down, so you need to downsize alcohol and coffee and upsize your metabolism. And one of the things that she really recommends to help upsize your metabolism is the Mediterranean diet. So, again, um, fresh, whole foods, lots of oil, small amounts of meat, and no processed food really. When you look at the traditional Mediterranean diet, lots of seafood, lots of olive oil, uh, and again, the lane way after 40 narrows, so you can't get away so easily with the alcohol, coffee, staying up late, and so this is what Moscone is referring to really in talking about helping invigorate the brain and protect the brain. Um, uh, Another thing that she really pushes is know your numbers and optimize. So it's kind of just, you need to know your lab numbers, not from only from a hormonal point of view, but also from a metabolism point of view, cholesterol point of view, sugar control point of view. And another pearl she often talks about is exercise. It's about consistency, not intensity. So it's more important to be regular with your exercise than it is to kind of do hard exercise. And I think we're all thinking, oh, we need to go to the gym and really punish ourselves and that boot camp mentality. Whereas in fact, it's more about lower intensity exercise, but being consistent about it. The other thing that's really interesting with her work and the work of many others is the role of mindfulness practices. And when I really started to dig down into the research around sort of mindfulness practices, it's really around the breath. And so they did a lot of mindfulness type uh, interventions without breath awareness and then with breath awareness. And then they did the same things with breath awareness but without any of the mindfulness. And most of the benefit from the mindfulness practices seems to come from what they call paced respiration. And paced respiration is where you have a slowed down respiratory rate, typically 6 to 8 breaths per minute. And there's just a slow, controlled breath in, and usually not always a slower, controlled breath out. Sounds super simple, but there seem to be some really profound benefits from doing that. And what Moscone was really pushing women to do, knowing that they're very busy, is to do your exercise and your paced respiration together. Do them in tandem. And she really named things like yoga, qigong, Pilates, just these functional exercises as examples of where these are things that are designed with breath awareness embedded. Um, Other things, non-pharmacological things that have been shown to be quite useful. Hypnosis. Hypnosis seems to be incredibly effective. And psychoeducation. Also, psychoeducation is essentially just regarding having a better understanding of what's going on to then be able to um, do some lifestyle changes to help sort of support that. Um, with a lot of things like herbs, with a lot of things like acupuncture, a lot of these things have been used historically for long for women's health. There's a lot of mixed results. And my feeling is it's not necessarily a single herb that's going to make a difference. It's often a blend of herbs that seems to make the biggest difference. When the studies show single herb interventions or multi-herb interventions. The multi-herb interventions seem to work um, usually very well. And uh, apart from a couple of herbs, there aren't many single intervention herbs that seem to be particularly spectacular. A good example is black cohosh by itself, not really a whole lot of convincing evidence. When you combine it with other things, seems to work really well. Um, the other family of herbs that's really worth talking about are what are called isoflavones. So isoflavones typically are sort of these antioxidant, usually colorful pigments found in plants. Um, and the isoflavones seem to be really effective because of their estrogen effect. They're thinking that in Asian culture, there are a lot of more of these in the diet, and this may explain why Asian women tend to have a lot less in the way of menopausal symptoms in the West. So when they look in Western cultures, only 2/3 of Western women actually have the genes to be able to activate a lot of these isoflavones. Um, so this is where maybe the studies are showing not such a great effect across the population, but these things I think are definitely worth trying. Um, and we might even see some genetic testing to see whether those things are actually uh, on on the menu, so to speak, or not. And really, I think that's again part of that individualization. Licorice seems to be the other herb that's very interesting as well, and helping in all of those four domains: vasomotor symptoms, uh, psychiatric symptoms, sleep, and um, sexual function. So, and that seems to be a little bit of a superstar. I think they're really trying to dig down what is it within the licorice that sort of helps with that. Christina's asking, do I recommend soy? So, soy's had a lot of bad uh, news, I suppose, over many years, and um, I think soy can be a very, very useful thing. I'm often looking what do they do traditionally to soy, and what do we in the West do um, uh, to what does the food industry do to soy that may make it sort of less useful? But I think most of the research is showing that soy seems to be pretty effective. I tend to go for much more traditional types of soy products. Fermented soy seems to be better, and traditionally prepared soy without too many additives, I think would be the way that I would go with that. But I think it definitely can be a very, very useful food. Uh, if there are any, a few more, if there are any more questions about sort of supplements, I think I'd like to do another session more around sort of management, but I just wanted to give a little bit of an overview. Really amazing how useful this paced respiration, hypnosis, psychoeducation, mixed herbs, um, and then really helping regulate your nervous system. And I think the thing that's been really missed um, is measuring the stress response in women in their 40s and looking at maybe longer term studies to see if that really helps with what happens when the menopause really sort of starts, because I think that's where it is. And just um, these idea of nervous system practices, I think, are profound and I think are really important for everyone. It doesn't matter who you are, but they're very important for mothers in their postnatal recovery, and I think they're very important as part of setting up for a healthy menopause. And what I mean by nervous system practices, um, now, my clients will often hear me say it's the equivalent of brushing your teeth. We brush our teeth not because our teeth are going to fall out tomorrow if we don't brush our teeth. We're looking at our long-term dental health, and with time, it feels odd when we don't brush our teeth. And so, a nervous system practice is a little bit like that. It's something that we do regularly, every day, ideally, and it should feel odd if we don't do it. And nervous system practices can be quite varied, but they always need to have a breath awareness aspect to it to get the full benefit. can be anything from a gratitude practice, a guided meditation, yoga practice, um, uh, mindful walking seems to be something that I'm seeing a lot of my clients getting a lot of benefit out of. Um, Craft can sometimes be that as well, especially if there's sort of the breath awareness with that, sort of getting into that creative space, and getting into a flow state, and then with breath awareness, it can actually become quite therapeutic. Um, yeah, so it's a big topic, and it's something that I've been called more and more to sort of talk about, as a lot of my mothers that I have treated are now sort of approaching menopause, or a lot of my older mothers with young kids are really, really struggling in this space. So I'll be writing more about this. I really want to be providing information in sort of summarized form to really sort of help the process of trying to work out what does the nervous system practices might look like, and then what do supplements and even pharmaceutical medications, the pluses and the minuses around those. But I think there's a lot of misconceptions. Are hormones harmful? Are they helpful? Do they cause cancer? Do they help with heart disease? Am I going to get more clots because of hormone therapy? And they're all pretty. And there's been a lot of conflicting information over the last 30 years around this. So I definitely want to talk more about that. So thanks for tuning in, everyone, today. And yeah, there'll be, let's keep this conversation on menopause going. If you have any more questions that you particularly want to dig into, please message me, and wishing you all the best.